Today, we will be speaking with Dr. Ted Rosenberg. Dr. Rosenberg has a very unique practice. He has had great success in helping elderly people to stay out of the hospital and live healthier, better quality lives. I think you'll find this interview very interesting and enlightening today. Dr. Ted Rosenberg completed his medical degree at the University of Manitoba with a specialty in community medicine and public health with a diploma in care of the elderly. Dr. Rosenberg is also a clinical assistant professor in community geriatrics with the Department of Family Medicine at the University of British Columbia. In 2003, he developed a unique model of home-based medical care for frail elderly people. This model uses an integrated team of physicians, nurses, physiotherapists, and rehabilitation aides to manage and treat people in their homes. An evaluation of his practice published in the Journal of the American Geriatric Society demonstrated that his unique approach to caring for the elderly resulted in a 39% reduction in hospital utilization, a 20% reduction in emergency room use, and that 48% of people were able to die in their own homes. In 2016, Dr. Rosenberg was recognized with an Award of Excellence from the College of Family Physicians of Canada. Dr. Rosenberg, thank you so much for joining us today.
Yeah, thanks for having me, Lindsay.
I'm really excited to discuss some of your work and the unique vision that you have for healthcare of the elderly. For those who don't know Dr. Rosenberg, could you explain to us what elder care is and how you got into this field of work?
So interestingly, I started out at the other end of the spectrum in pediatrics. So I did a year of pediatrics and thought I was going to do pediatrics for children with cancer and blood diseases. And ended up taking a year off and went up north to Churchill, Manitoba, because I trained in Winnipeg, just to see the world and to, get out into the real world and, practice some medicine, and fell in love with it. And, ended up working up north for 5 years and decided that I had my trade, but I needed an education. So, I knew how to, fix people, for certain conditions, but I didn't really understand why are people in this, these adverse, positions to begin with. Mm-hmm. So for example, working, in First Nations communities, there are problems with water, sewer, housing, things that we're hearing about right now. Well, that was happening in the, all along. And certainly when I started working in the late 80s. So I went back and trained in public health and community medicine to learn about the big picture, what are the determinants of health status, and then how do you plan a program to try to improve people's health, health and health care. And did the public health training not diploma, but fellowship. Mm-hmm. But at the end of it, I knew that I still wanted to be a hands-on doctor, and look after individual people as well. And I thought to myself at the time, having sort of worked for 5 years out in the community, is that the part of clinical medicine that I really enjoyed was working with elderly people. And, I think there were a number of reasons for that. One is that people often have very complicated problems, medical problems. They may have like 8 diseases. Yes. So it forced me to be up on my medicine, to be sharp, to be attentive. The second reason is a lot of these people were very neglected. And, there was a need. I saw this was not, elder care, geriatric care at that time was not a priority, for people training in the healthcare field and certainly in medicine. There was a shortage, and I felt like here was an area where people really need good care. And the other piece I really liked, I think, which comes back to my training in pediatrics, was that there's another layer. It's not just what's the diagnosis, what's the disease, what's my medical treatment going to be, but it's how does this impact someone's daily functioning? Impact their quality of life, this problem. So if you've got congestive heart failure and you're having trouble breathing, suddenly you can't visit your friends or your family, because you're too tired or you can't do your housework. So, that added another layer and then one more layer. And that layer was, even when we've sort of established what the problems are and some of the medical problems underpinning them and how they're impacting people, it was another decision point was, what do people want? Which wasn't part of our paternalistic medical training. So I had a lot of people in their 90s who weren't interested in living another 5 years, but they were interested in having medications that will reduce their symptoms or will allow them to stay in their homes. So I really enjoyed that complexity and in that perspective, and that sort of drew me into geriatrics.
Wow, that's quite a history there. That's very interesting. And of course, when you encounter these patients, like you said, they do have very complex medical issues. Could you explain to us how the body changes, when we age, what changes, I guess, does the body go through, and how does that impact chronic disease, medications, that sort of thing?
Sure, certainly. So, aging is very topical. Western societies are aging, and mid-income countries, developing countries are also aging. Mm-hmm. And with that, that's bringing a whole number of issues and challenges, socially, economically, culturally. So, what happens when we age? There's really a couple of things that happen. One is that over our lifespan, we have injuries, right? And so we fall, we injure ourselves, we may break a bone, tear a muscle, whatever. We may do something to our bodies that causes an injury. For example, smoking damages lung cells. Mm-hmm. And there's accumulation of these injuries over the course of time. The other thing that happens is that, in a lifespan, our body is a very, busy entity, and it's constantly, we have metabolism. And our metabolism are all the cellular events that happen to keep us going. Make sure we have enough energy, to make sure that organs are functioning properly, to make sure we have the right, enzymes and proteins. That's all governed by metabolism. Now, part of the problem with metabolism, all of these, things that happen is there's waste, right? So, and these waste products, for example, if we have too many nutrients, and we can't, we'll store them as fat, and some of them will build up in tissue. What happens then is that this waste product starts to affect cells. So the combination of injury, of too much waste over time, and a problem with disposing of the waste, and finally chronic diseases. So people have chronic diseases, and this damages our cells. So, emphysema, people have damaged, lungs. Cirrhosis, people have damaged livers. So when you start to get this damage, and it goes beyond just damaging cells and causing cells to die or malfunction, but starts to affect a whole organ, okay, that's when people, start to become frail. And then they also run into problems.
And so you mentioned frailty there, and I wanted to ask you, what is the definition of frailty, and how does that differ from someone who is well and elderly? Frailty is actually, there is a definition for this. Is that correct?
There are definitions, but one that I find practical too is that frailty is when these this organ damage and loss starts to affect people's daily function. Okay. And then the second part to it, and we'll talk about this, is not only does it affect their daily function, but it also makes people more vulnerable. So if we sort of pick up where we left off, eventually what happens with people with these sort of accumulation of damaging events over a lifetime is people become symptomatic. So, for example, normally we lose a little bit of lung function with age, but it doesn't affect us. But when we get to a certain age, we may not be able to sprint because we don't have the same reserve. Some of those lung cells have died off. Mm. People, you add on to that smoking, and someone develops emphysema, and they become, symptomatic much earlier because they've lost, even more so lost that reserve. Eventually people have chronic symptoms. So people go from saying, I feel short of breath all the time. I feel short of breath. I used to be able to walk up my stairs, and now I can't because I'm just so breathless doing that, right? Mm-hmm. So people enter a pre-frail stage where they've got chronic diseases like heart disease or hypertension or diabetes or lung trouble, and they become symptomatic most of the time, and they start to curtail some of their activities, but they're still independent, right? So we would call that pre-frail. When that progresses more to the point where they have difficulty remaining independent, that's what I would call frail. So, for example, someone who's got damage in the brain from Alzheimer's disease eventually gets to the point where they can't balance a checkbook. They may not be able to shop, plan a meal. They may not be able to cook a meal, etc. Plan look after their medications. So that's when that sort of chronic damage that's been happening with Alzheimer's disease over years starts to affect function. Okay, and then they have mental frailty. Someone who, if we take our example of somebody with, advanced emphysema, or even somebody who, has got arthritis, and they can no longer, mow their lawn, they can no longer, use a vacuum, they can no longer, make their meals because they're too fatigued standing, and as this progresses, it may get to the point where they may have trouble not only managing their household, but they may have trouble managing their personal care. So people may get to the point where they just can't, they're too tired to dress or bathe. So what I'm trying to say is that frailty is multidimensional, so it affects can affect us cognitively, mentally, physically, socially, and it also exists along a continuum. So people can start off pre-frail and gradually decline into, a little bit more frailty, need help with household management. And then as they get more frail, they may have trouble walking, falling, and need help with personal care. Second piece to the frailty besides the function is that people become vulnerable. And this is really a very, very important piece and concept, and this often leads to a lot of the hospitalizations and emergency use and premature death. Right? So if I get a bladder infection, I'll have burning when I pass my water, it'll be annoying. I'll take an antibiotic, I'll get better. Okay. If a frail person gets a bladder infection, okay, they can develop fever, they will get confused, they can become very weak and start falling, and they may not even have symptoms of, burning in their bladder. They're just going to crumple and end up in emergency. So they don't have that reserve, to tolerate an illness. Similarly, if I fall on my behind, I'll have maybe a worst case scenario, a little bit of a bruise. But if a frail person falls, just falls gently onto the floor, they could break their hip. So there's that element of vulnerability, and that's sort of a key part. So the two parts really are people become more dependent, they need a little bit more help with their function, and they become much more vulnerable.
Mm-hmm. And I know that a fall in the elderly can be life-changing. It can sometimes even be a progression to a shorter life. I know that falls are one of the main causes of death in the elderly. It's very serious. We think, I fell, I broke my ankle, not a big deal, right? But falls in the elderly are very serious. So breaking your hip when you're elderly, when you're vulnerable, that can cause a whole cascade of issues. Is that right?
Absolutely. And it's devastating. So we see people who are still functioning, they walk downtown, they visit their friends, they're managing, and all of a sudden, boom, their life changes. They need emergency surgery. They may not heal. They may get complications, from their frailty in hospital, like pneumonia or blood clot, or delirium, confusion. If they recover from that, then they may end up with, permanent problems with their hip and need to walk with a walker. And 25% of people who break their hip never go home, because they can't manage anymore, So you can see that one moment in time can absolutely turn someone's life upside down and have a very profound effect. I want to say that not everyone who falls and breaks their hip or falls ends up, in the worst case scenario. And, a lot of people die from hip fractures too. In fact, most people recover. People are resilient. That's always, takes my breath away, is how people have gone through these injuries, and they just, they get up, they do their best, and they do their best to recover. And, that's one of the things I love about geriatrics is, if you pay attention, do things properly, you can really help people along that recovery phase so that they can then do what they want to do.
And your practice is quite unique, Dr. Rosenberg. You have developed, I guess it's a model of practice where you are actually a physician who still goes into people's homes, and your goal is to keep them out of emergency, keep them out of that type of care, and try to keep them in their homes. Could you explain to us what your practice looks like? Because I feel like it does not look like the traditional practice that we're used to seeing. A lot of people in Canada don't even have a family doctor. And the patients that you're caring for, you're actually going into their homes. This is almost unheard of. So can you take us into your world a little bit and show us what your practice looks like?
Certainly. So I'll just start with a little anecdote. When I first started this practice, and I was kind of uncertain, is this going to work or not? One of my patients, when he met me, he says, "Doc, you're a dinosaur," right? Because nobody goes in to do house calls, and you these people in their homes. So I started my work in geriatrics, as a consultant, seeing people for assessment of geriatric problems like balance trouble, fatigue, cognitive impairment, things like that. And what I found, first of all, is that there's an issue of access. So a lot of people, had trouble getting into the doctor's office.
Yeah.
You can imagine someone with cognitive impairment who doesn't have family at home, someone with Alzheimer's disease, they're going to forget they have an appointment. They can't organize a transportation. It becomes a challenge. Someone with a physical problem, we see people with severe chronic pain. They can't sit in a waiting room.
Right.
They can't sit for long. They can't walk, or they may be incontinent and feel shame. Things like that. So there was an issue of access, of people getting in to the specialty clinics, but also, this is a big problem in primary care.
Yes.
So that was one element, is how can we improve people's access? The second thing that I was interested in was how can we help families? So a lot of families would take time off work. The wonderful people, again, one of the things that takes my breath away, the people that we meet, and you'd see these families are so devoted to their parents or their loved ones, and they'll lose half a day's work taking them into a clinic, and repeatedly. And often they often feel that they're not included as part of the team and struggling to get the health information from the system. So I felt that that's something that really needs to be addressed, because if we don't support the supports, the whole thing falls apart like a house of cards, right?
Definitely. Mm-hmm.
The third issue was that in traditional medical care, geriatrics is different, but like if we move on to primary care, the way it's evolved is that people have one problem per visit, because of the way, it's complex issues and there's no one to blame, but that, it doesn't work for these people. These people have complicated problems. They need time to, because one problem is related to another. So if you don't deal with it, it's going to come back, to haunt you. So I felt that people needed more time for their assessments and their care. And, finally, I would say that one of the things I learned is that, is the importance of primary care, is longitudinal follow-up, following people, being their doctor. So as a specialist, when I was working in a geriatric clinic, I'd see people a couple times a year. But, a lot of the issues that we see is, we need to keep making changes. I may think that this medication is going to help someone, but it may cause problems. So we need someone to follow up, feedback, adjust courses until we get it right. So, that's what the advantage of primary care and having a doctor who knows you. They know you and they can see when things aren't going well or when they're going well. The other part to that primary care is that, people need to trust, their healthcare team, and trust takes time. And it takes time, and the relationship needs to be built. And I found that, that by investing in longitudinal care, when push came to shove and people were in trouble, they trusted me because they knew I was going to act in their interest. I knew them, I knew what their sensibilities were, and then I could, represent them as such. So, for example, let's say someone has a misfortune that is just no longer working in their home that they've lived in 60 years, and they need to go into assisted living, and I explain to them and say, look, we've done our best. Here's where we're at. You staying at home poses all these risks, etc. People trust me, because I've been there for them, and because, there's that relationship that's been built. And similarly with our team. So, for those reasons, I felt that, we needed to change tack. We needed to see people in their homes. We need to support the families and not only families, we need to support the healthcare teams in the community. The home care, are on the front line, and the healthcare aides. All those people need support, and we're all part of the same team helping individuals. Now, the other piece that is different in our practice is we're like a geriatric hybrid, right? Okay. So we do that comprehensive geriatric assessment, which is what holds, and we follow people longitudinally. So what does a geriatric assessment look like? Basically, is we try to do a comprehensive assessment of people's, physical health, their mental health, their psychosocial health. Look for, the determinants of where things are going wrong. And then what we do is, for me as a doctor, I try to optimize people medication, make the right diagnoses, make sure all that's right. But there's so much I can do. Everything gets so much better when you add a team in. I'm a doctor. I'm not a physiotherapist, right? So I can treat people's pain, but the physiotherapist can make that pain even better and translate that into them being able to walk again. Mm-hmm. And similarly with nurses. Nurses offer so much more than what I offer, and they can take the time to explain to people and deal with, a whole host of issues, and other team members. So the difference with geriatrics and sort of usual primary care is that we use a team, and that the sum of the parts, or the whole is much greater than the sum of the parts when you do it that way. Mm-hmm. So that's sort of, the way we operate.
It sounds amazing. And one of the things that I know you try to focus on is you focus on patient-centered care, and you come up with a care plan that works for the patient as well. And I think that even as myself as a pharmacist, we're often thinking about evidence-based medicine and what is the best thing for the patient, but it's not always cut and dry like that, right? So when you go into someone's home and when you see how they're coping with, say a person who is on 8 or 10 medications and is, the first time you've maybe seen them, what kind of issues do you tend to see right away, and how do you develop an individualized care plan for this person?
Certainly. So I just want to back up a little bit.
Sure.
About the home, because it brings to mind something, how important it is to see people in their own environment. So I often would see people with, for example, advanced dementia, in the clinic, where the family says they need to go into a nursing home, into a care home. Because they, we look at their score on their mental status test, and they're like, bottom third, and it looks like they have significant, cognitive impairment that's affecting their function. Now, that person, when you go into their home, they've been living in the same home for 70 years. It's spotless. Everything is in place. There's food in the fridge. Why would you wrench this person out of their home and move them to somewhere which is definitely going to confuse them and disorientate them, right? Mm-hmm. So the just seeing someone in their own environment is priceless. It's just, it's so important. On the other hand, looking, the home environment and the fact that we follow people up in their homes, long term, is that often I'll walk into someone's home who I've known for a couple of years, and right away I can tell, there's trouble, right? Mm-hmm. The person was fastidious, and now I'm seeing papers on the floor. There's no food in their fridge. Their blister pack, for their medications is a mess, and they're in trouble. And they're in trouble because of an underlying medical event that's happened, like a stroke, right? So that home environment that you would miss in a clinic because they present the same, they normally enact, that would be completely missed. So that's the little sort of digression about importance of. Now, how do we set up a care plan, with people? I think that's what you're asking, Lindsay, right? And So one of the things we want to start with always in our assessment is to make sure that it's accurate and useful, when we see people. So, one of the other differences that we do compared to usual care is we try to measure people's health status in a broader sense and measure their level of frailty. So a number of years ago, I sort of thought we could do better with this. So let's look at what are the best tests for function and frailty, that are out there, people have studied. And let's assemble them and let's turn that into our assessment, part of our assessment, in addition to what's their medical history and what drugs are they on, et cetera. And so what we do is we do about 7 or 9 tests for people. It takes about an hour. And we measure, and recognizing that frailty is, multidimensional and exists along a continuum. So we'll measure people's cognitive function with a standard test. We'll measure their mood, because depression is a common problem, anxiety. We'll measure their attention span, which is a good marker if people are acutely ill. They lose their attention first and have delirium. We'll measure their physical health. So we know that walking speed, if it's measured properly, is a very strong predictor of death, of falling, of breaking your hip, of having to go into a care home.
Wow.
Okay? And going to hospital. So, and the slower your walking speed, the worse it gets, so by doing a simple test of walking speed, we call gait speed, and we're not doing racing. We don't tell people to race. They walk at your comfortable speed. And, it makes sense if you think about it. When people think about older people, and so that sort of meme of a frail person is sort of bent over and shuffling, Yeah. Imagine that walking slows down for many, many reasons. The other thing we measure is people's grip strength. We found that grip strength we looked at the literature, and it's a stronger predictor of death than systolic blood pressure, if you can believe that.
Interesting. Wow.
And then we take it one more step, because to me, for people, like you say, their goals of care are quality of life. What's quality of life? It's a good question. And people, a lot of people, smarter people than me have worked on that. How do you measure it? So the health-related quality of life, really, we look at 2 dimensions to it. One is symptoms. So some people, if you're in pain all the time or you have severe anxiety, it occupies your life and it's hard to do what you want. The second piece is your function. So how does that affect your ability to do usual activities and personal care, et cetera? So there's a test you can do. It's 5 questions. We call it EuroQual test. Highly validated. It's used around the world. Right? We brought that test into our assessment and it gives us a very accurate picture and a very strong predictor of, adverse problems. So we do these various tests and we get a number with people, so we get, this is your score on each of these tests. And right away with that number, we know, how much trouble people are in, that there's issues that and the other thing that we found is we followed people up over 4 years. We did a study through University of British Columbia, and did these measures on 300 people. We followed them for 4 years, and we analyzed the data for the first 18 months. And we found that these measures of frailty, so gait speed, walking speed, cognitive impairments, quality of life, grip strength, were much, much stronger predictors of death, a stronger predictor of going to a care home, and a stronger predictor of going to hospital than any combination of medical diagnoses, any number of drugs that people are on, and any single diagnosis, including having cancer. So to give you an example, if someone was on the bottom, bottom rung for walking speed, they had 5 times the risk of dying in 18 months. 18 months isn't long on the horizon.
Wow.
Someone who had cancer, metastatic cancer, they had 3 times the risk, 2 to 3 times. So these measures were all very strong predictors, which was really surprising, but helped us then pass that information back to families and the person, so they could decide on what kind of care they wanted. Gave us some prognosis. And the other thing it helps us with is we can then we can evaluate, what we do and try to improve what we're doing. So there's another piece to having those numbers. So we use that information, plus the medical assessment, plus the team assessment. We roll it up. We sit down with people. We say, here are the problems that we can, you've identified. Here's what we think is fixable. here's the medical pieces that I'd recommend. We'd like to throw the team at you, to do their magic. And then we can see how things shake down, over the next couple of months, right? So, for example, a lot of people don't like to exercise. But when we sit down with them and show them that, look, your walking speed is like 0.6 meters per second, that's very high risk for you falling, breaking your hip, and having to leave your home, and you may not get back home, their attention is perked. And they say, maybe I should do the exercise program, right? So what we do is we use that information to help people make decisions. And then we say, okay, here's my part, as an individual. So my main priority is to reduce the level of pain. My second priority is that I can, walk outside again. So I can, see my neighbors or see my friends or go out. My third priority is to not have urinary incontinence. So we'll identify what their priorities are. Now, my priority may be as a doctor, I may find they have atrial fibrillation or they have severe coronary artery disease, and we should put them on a statin drug or a certain kind of drug, that will prevent that. They may turn to me and say, I don't care. What is that going to do for me as a person? So I say, well, it may prevent a heart attack, right? And a heart attack may kill you. And then they say to me, I'm 95. I don't want to live longer, right? It's good for me. So that's not a reason to go on that medication for me as an individual. You may say, well, you may end up with congestive heart failure and you're going to have trouble, breathing. You say, well, I can hardly walk now anyways, and that's not getting better. So you can see how you can individualize care. And on the other hand, I may have someone who's like paraplegic, from had a stroke, and for them, every second of their life is important to them. So, prolonging their life for that person is a priority. So we will do what it takes, within reason to help prolong their life. So that's the individualizing of care, sort of trying to individualize things, recognizing that every person is an individual and they have different sensibilities and different goals. And then the other challenge is sort of lining up the goals of care that individual may have with the goals of care of the family. So you sometimes have that tension where the family wants safety. They don't want their parent to fall or be on the floor or injure themselves. But for the person, the elderly person, they would much rather be in their home rather than a safe environment. So you need to make trade-offs and you need to accept risk. So, that kind of dialogue goes on. So that's part of the sort of individualized care plan. And then we set up that care plan. And the other part to it, because we have these valid measures, these numerical measures, we can repeat them and say at the end of the day, after a month or 2 months, are people better or not?
Right.
And maybe we need to pull back here, add something here, shift gears.
That's really interesting. And I know as a pharmacist, I've found that often we'll have patients, because I think the type of practice that you do is it's rare to find. It's a rarity. We'll see patients come in and often they will say, well, here's my prescription. I guess I have to take this. And they just add it to the list of medications. And you can already tell, for me, it's already a red flag because, okay, so it sounds like this patient doesn't really understand why they're taking this medication. They don't really want to take it, and if you don't have the patient on side, or if it's not part of what they see as important, then that can be an issue with their care as well, right? And having the patient on board and caregivers on board, I think is vital. And just keeping in mind what their goals are. So, you can, because a lot of people, maybe if we're talking about medication, you can pile one medication on over the other for every issue or every symptom. But if the patient's not taking the medication, if they're taking it every few days, I mean, what is the point of this? And what is the overall, how is it really helping in the end, right? Medications,
you raised some really important issues. Medications are a huge issue with older people. And I'm glad you raised what's, may not be important to them. So sometimes I'm in a position to tell people, you don't want to go on, you've got atrial fibrillation that we found in the regular heart rate. This increases your risk of stroke. They say, well, I don't care if I die from a stroke. Well, I say you may not die from a stroke, but you may end up with losing your ability to speak and communicate. You may end up in bed, with paralysis, and not die for 2 or 3 more years. Is that something, So for those, I would ask you to consider going on a blood thinner, an anticoagulant, right? even though there's risk with an anticoagulant. So that's that individual and trying to advocate in the to and fro, with people. With drugs, drugs have a lot of bad press, with people, and rightly so. There've been a lot of related, issues. So, for example, anti-inflammatory drugs, you're aware of this, which are commonly used for sports injuries like ibuprofen or aspirin or naproxen. You can buy them over the counter. Well, in the 1980s, the problem with in the 1980s, anti-inflammatory drugs were the number one cause of hospitalization in the United States.
Wow. And
the reason for that is in older people are frail. Remember, you lose cells, you lose organ function and organ size. So if you put an anti-inflammatory into a very thin lining of a stomach in an older person, it'll form an ulcer and they'll bleed. And they'll end up with a hemorrhage and end up in the hospital. And similarly, people who've lost kidney function over time, you add an anti-inflammatory, it can cause kidney damage, right? With silent, and suddenly they show up and what's going on here? So, drugs can be dangerous, right? But on the other hand, as you mentioned, drugs can be not only life-saving, but they can significantly improve people's quality of life. Significantly. Yes. So, for example, someone's got congestive heart failure. I had a lady I saw the other day, very short of breath. She has new congestive heart failure, having trouble, with fatigue, having trouble sleeping because she's breathless. Well, if people have a little damage in their heart and their heart isn't pumped properly, you often need 4 or 5 drugs to get everything working properly, right? So that's 4 or 5 drugs that you've added into their regimen, right? But at the end of the day, it's like, oh, I can sleep again, I can breathe again, I can walk again. So, the issue is not the number. Yeah. The issue is the right drug for the right person at the right time, for the right condition, right? Mm-hmm. So one drug may be good for a younger person who has rheumatoid arthritis, but it may not be good for an older person. But there may be another substitute, okay? So, it's really important, with medications, that you have the right drug for the right person. There are other considerations with older people. As people get older, their kidney function drops, so they can't pee out the extra, the drug, and they can build up and cause toxicity. So we need to know, that piece. And the kidney function can change rapidly with people, so you need to monitor that. The other issue that, as you well know, is that there's, when drugs compete in the liver to metabolize, to be broken down and peed out. So you want the drug to have the effect, and then you need to get rid of the extra, right? So, if someone's on multiple drugs, they're competing for those enzymes to break it out and pee it out. And sometimes one drug level will go high and become toxic. So we need to be aware of those drug interactions, with people. And that's where you need the expertise of pharmacists, also part of the team. To look at that, to look carefully, to screen for interactions, to bring it to my attention and other doctors' attentions.
You mentioned there's something about medication being specific for the individual. And I wanted to ask you a little bit about pharmacogenomic testing, because I think, is that something that you're currently doing in your practice or getting into?
We're just starting. So what pharmacogenomic means is we know that, simply that there are certain enzymes in our liver that are dedicated to detoxifying our body. So to get rid of foreign toxins. So, for example, if there's a chemical in your body, there's a pesticide, they will break them down and we can pee them out, right? They're out of our body. Drugs are foreign compounds, and they're handled the same way as these toxic compounds. But there's a little bit of benefit to them, but there could also be risk. There's what we call that, therapeutic window or index. So what we know is that there's certain people, their genes are different. So the genes are the recipe book to tell us, how these enzymes are going to work. So, for example, I had my genes tested, and turns out I'm a very slow metabolizer of caffeine in coffee. Okay, so if you look at the enzyme that breaks down caffeine, some people are very rapid metabolizers, so they burn it up as soon as it comes in. Those are people that are drinking 1.5 liters of coffee just to get enough caffeine to wake them up.
Right.
in my case, because I'm an ultra slow metabolizer, if I have a cup of coffee in the morning, it's still going to be in my body at bedtime, right? If I have 2 cups of coffee in the morning, double trouble. So I may find, gee, I'm having a lot of trouble falling asleep. I can't wind down, right? So that would be a benefit, of knowing that. So I can say, and some people know it anyways, right? They know I can't drink coffee. If I do, I'm not going to sleep. But some people don't make that connection because I only have my coffee in the morning. So it can't possibly be doing this to me. Similarly, I'll give you an example for myself for pharmacogenomics. There are enzymes that break down, commonly used drugs for stomach acid. We call proton pump inhibitors like pantoprazole, right? And there are different types of these drugs. These proton are metabolized through, different enzymes.
Yes.
Pantoprazole may be metabolized through one enzyme, and another one, lansoprazole may be a different enzyme. So in my case, I had trouble with heartburn at one point in my life, and I was taking this drug, and it's very expensive. It's like $100 a month. I didn't have insurance, and for most people, 80% of people, it's magic. It's the burning away. It's miraculous, right? In my case, it didn't make any difference whatsoever, and. Wow. So, it was either I'm a crock with my doctor, this isn't working, or there's something really wrong. When I got my pharmacogenetics testing, it turns out that my enzymes are ultra rapid metabolizers. They burn these drugs up as soon as they enter my body. So they are not going to work.
Wow.
You can imagine if I knew that 2 years earlier, I would have saved myself hundreds and hundreds of dollars, and I would have changed courses and looked at different ones that are more unique to the enzymes that I have that work, to let this drug work. So pharmacogenetics can give us that map. The other thing we can do, testing our genes, we could test for allergies. Some people, we can know that certain genes will predispose people to allergies to, for example, anti-epilepsy medications. You can identify that. It makes it easier for us to match the right drug to the right person in an individual way, right? To that person. Now if I give someone an antidepressant, I'm guessing.
Yes.
I'm just guessing, 20 antidepressants. Okay, I want to leverage it for this, reason. But, I hope it works because it works in 75% of people, but it may not work in, that other 25% of people, not because the drug isn't good, but because their genes may burn that drug up. Or cause side effects, one way or the other. So what we're intending to do is to start to test everyone's genes for this to get a profile, because there are companies that will give you a profile of how they will metabolize drugs. So we could start, it'll give us a leg up. So pharmacogenomics now are not widespread in medicine.
Yeah.
It's amazing, with human genome technology, right? You can sequence someone's genome in hours, right? And know this information, with a swab, tissue swab. Pharmacogenomics are being used in cancer care. So, for example, if someone is a very slow metabolizer of a type of chemotherapy, it'll kill them because it just builds up and builds up and builds up. So, say they'll test the genomics and say, don't use this drug.
Right. Of course.
Right?
Yeah.
Save people's lives.
Yes.
Pharmacogenomics is being used in mental health and psychiatry, where people have very complex, problems, with depression and bipolar disease, and trying to again match, the right drug to the right person. So, because our people, not everyone needs a pharmacogenomic test, but our patients are on an average of 6 drugs. They've got multiple diseases, complex problems, a lot of drugs. So, I think it's best to know if we're going to pick a drug, let's pick one that has a higher probability of doing what we want to safely. We will be testing people, we're going to be starting that, and we're also going to evaluate that, to see if it's helping, us make decisions.
And it's such a vital piece of information that we can use now, because as you said, it has been up until now a little bit of trial and error. And I remember this, like with my patients, they'll come in and say someone has depression, and the doctor tries them on citalopram, and it doesn't work for them. And then, you have to wait a couple of weeks because these antidepressants don't work right away. So, well, maybe it's just not working, and then, 2 or 4 weeks later, we try a different one. And I know patients have said to me, do we have to keep doing this? And it's not only an issue of time, it's also very expensive because the patient is paying for this medication that may or may not work for them. So individualizing this and having that information could definitely give you more information as to how to prescribe for them, and then hopefully more effective care. Because especially when you're working with older people, time can be quite crucial when you're dealing with certain issues. Is that right?
That's right. If someone has a life expectancy of a year, you want to spend 4 months trying to get to the right antidepressant by trial and error. So really good point.
It's really powerful tool. And so as we head into the winter, Dr. Rosenberg, people who have listened to our conversation here, I know that we're still in a pandemic, and I know that COVID-19 has taken a terrible toll on the elderly in our communities. For people who are listening who may be elderly themselves or who maybe have family members who are elderly, do you have any advice for how to kind of navigate this next few months? I know that you have probably seen a lot of unfortunate things throughout the course of the last 18 months. Do you have anything you'd like to share with us?
First of all, just on the COVID issue, COVID was devastating especially for elderly people.
Yes.
People were locked up in their congregate living setting, like a retirement home or assisted living, for months, where they were only allowed out once, for an hour to walk.
Yeah.
And they weren't allowed to see their families. So it was just a very, very difficult time. And I'm just in awe of how people got through that. And I saw so many people who were like stiff upper lip and, we're together within the home and we're going to support each other and we're going to make the most of this, right? And we saw consequences, also those people who became depressed, as you would expect. We don't put people in solitary confinement, almost all, prisoners, so you can imagine for someone who's frail and older. The other thing we saw is that, people got really deconditioned. They stopped walking. They became weak and they started falling. And we're still cleaning that up, and trying to get people back up to their fitness level. So I am just so happy this vaccine has been a miracle, because it's taken this thing which was, almost a death sentence. I don't know what percentage, but 10% of older people got COVID. At least would get very ill with it, and people would die. To something where it may make you a little bit sick, but it's less likely to kill you, right? Mm-hmm. Now, we need to still be careful with COVID, right? It's not, we're into a fourth wave now, and, all those public health measures are effective, social distancing, masking, but at least now we can interact with each other, safely with the vaccine. Winter is a tough time for older people.
Yeah.
I just, to talk to that for a minute or two, is, my experience, and not just for older people, but younger people too, is that a lot of people are very light sensitive, right? So suddenly when the days become shorter, we see a lot of people get what we call seasonal affective disorder, affect, how you express your emotions. So people get depressed. A lot of people may not feel depressed, but they just feel lethargic and awful. And they just don't feel well, just, struggling. And often there's, and the good news is that is effective treatment for that. There's something called a SAD-LAM. Powered lamp, it's 10,000 lux intensity of light. So it mimics, summer daylight. And you just spend 20 minutes having your coffee in the morning with that. And often that will really reduce those symptoms and put more of a spring in people's step. So, there's that part of it. So it's important for people to think about that if they're, tend to get a little depressed over the winter time. The other is to make sure they're fit, because when you stop walking outside, maybe raining or the weather may be cooler, people get weaker. And when they get weaker, they start falling. And not only that, they don't feel good. We know that aerobic exercise, like getting our heart beating, is a great antidepressant. Feel better. So, there are all those other parts to winter. So make sure people keep up with an exercise regime. If they can't do it outside, do it indoors, because a lot we can do indoors. Watch your mood, stay socially active as much as you're able to, and mentally active.
And I guess for someone who has a family member who is elderly and living on their own, I guess some signs to watch out for would be a person who is not doing those things, who is starting to withdraw from those activities. Is that right?
That's right. That's right, Lindsay. So, I mean, people don't think a phone call is important, but for a lot of people, it's a lifeline. And it's, very important, special part of their day. Is telephone visits are great visits for a lot of people.
Mm-hmm.
Video visits, when people are able to, have an iPad or whatever, can do video visits. So you may not be able to see someone in person, as we've learned with COVID, because we weren't allowed to see each other, but those other visits are pretty close seconds. So, making that phone call to your family member or friend or neighbor really makes my experience.
Yeah. That's great advice. Well, thank you so much for spending some time with us today, Dr. Rosenberg. I'm sure we all are much more educated about how to care for the elderly in our society and how you're caring for them in a very unique way. So I will put links to your practice, and people can figure out where to find you in the description of the video. And I look forward to having more conversations about this. I think it's a really important topic that we could all become more educated on.
Thank you, Lindsay. Thanks for taking interest in older people and frailty syndromes and how to make things better.
Definitely. Well, take care. All the best.
Bye now.